All right, so insulin itself, so insulin therapies, right? So outpatient wise versus inpatient wise. So outpatient, we said they get insulin to mimic the pancreas if they're type 1 diabetics. So they get a basal insulin, right, just to start. And our basal insulins are glargine, our degludec, edetamere. Those are our long-acting insulins, right? So those are long-acting. They're going to be, it's a baseline insulin release, right? And we have to, our pancreas does that, and we have to mimic that with a patient with type 1 diabetes. And then whenever you have a meal, your sugar goes up, and we don't want to get crazy, so that's why we give preprandial insulin. We give insulin before they eat, right? So we have long-acting and short-acting insulin is usually the go-to for a type 1 diabetic. For a type 2 diabetic, we want the sugar under 180, which is great. And these guys are going to, they're going to be on basal insulin for to get the sugar under control, to get that sugar under 180 in the hospital setting. And going back, sorry, to outpatient wise, is insulin prescribed to type 2 diabetics? Yes, it's type 2 diabetics also get insulin when their A1C is 9 plus. So it's just because the PO agents can help, but usually we're going to start them insulin right away to get the sugar under control. Now going back to the hospital setting, they're stressed, they got the SNS firing off, they got the cortisol firing off, and the sugar's high. And we want the white blood cells to work, so we got to get the sugar under 180. So both our type 1 and type 2 diabetics are going to be on basal insulin. Now the type 2 diabetic might not be on insulin at home, but in the hospital setting, we want to make sure that their white blood cells can work and they get out of the hospital quicker. Okay, so this happens especially like surgery, infections, stress, and ICU, right? So with that sugar under 180, that's the goal for our patients. All right, so you could have like DKA HHS, which we'll get to shortly, but you have someone who has type 2 diabetes or someone who has type 1 diabetes. These guys are started on a regimen of insulin. It's usually basal and preprandial, all right, to get that sugar under 180 and controlled. We might start the PO agents if they can take them. Otherwise, we're going to get them, we're going to try all kinds of tricks and tribulations or trials and tribulations to get the sugar where it should be, right? A combination of fast acting or rapid acting and a definite use of our long acting insulins. Okay, talk about our long acting insulins. These guys they take about 1 to 2 hours to take effect, right? So you might see these be prescribed for patients coming off of DKA protocols or off HHS protocols. So these guys, you're going to start them on insulin infusion when they come in with this complication, and then we have to transition them to a sub-Q insulin therapy. So we're on continuous IV insulin therapy. Now we're going to start sub-Q insulin therapy. It depends if they can eat, depends if they're obese, depends if they're thin. There's different things that we can look at, but usually about 0.2 to 0.3 units per kilo is about approximately how much insulin they should be getting. And usually they divide that amongst meals as well. We'll spell that out a little bit more on the next slide. All right, so you got long-acting insulins, and then we have our short and rapid-acting. There's really no difference or research that I know about that, like which one's the best one, right? Is it Lispro the best, or glulycine's the best, or regular insulin's the best, or is aspart the best? I think they're pretty much equivalent. It's just based on whatever the drug rep got the doctor out to lunch or breakfast for first, right? So there's really no big difference between these guys. The key thing is that you have to know that they have to be eating, right? They have to have food, visible if they're able to take PO to get that under control. NPH, 70-30s, all those other combinations, those are usually phased out because now we have long-acting insulins. We have Lantus or edetamere, or we have our glargine and such. Right? Those guys are our long-acting insulins are much more have better control of glucose compared to our ones that only work about 8 hours on average. And these guys are going to, you have these big swings in their sugar, which is not very predictable. Compared to Lantus, or I should say glargine, this guy is going to be very predictable. It's going to start in about 2 hours, and it's going to reduce your sugar by about 10% or 20% or 30% based on how high your sugar is and how high your dose is. And then whatever is above that, that's where we add on sliding scale insulin, right? When the sugar is over 180, over 160, 150, 140, whoever the lab director is at the time that makes that decision about when we're going to start covering insulin. And then we cover the insulin. If you're giving a lot of high dose insulin, usually start like a medium dose or moderate dose. If you're giving a lot of insulin a lot of times and the sugar is still over 200, you have to then increase from one scale to the next scale, right? Or if you're already on the high scale and you're covering a lot of insulin, you're giving like 12 units, 24 units, 20 units, all these units just to get the sugar down to 270, then you got to progress to IV insulin, right? You can try to, do the long acting and see if that works, but you have to probably switch them over to hyperglycemia protocols where we get their sugar under control with IV insulin. And what's the only insulin that can be given IV? That's a regular insulin, right? Regular insulin is the only one that can be IV. Okay, so that's the idea behind insulin therapy, right? Is to get the sugar under 200, and we have patients in the hospital. We want it under 200 with long acting and with some sliding scale coverage. They might get some sliding scale coverage, some long acting, and some preprandial insulin. So those are kind of your three combinations. So inpatient diabetes, again, under 180, right? Or over 180 is technically hyperglycemia. In the ICU, we want 140 to 180. They did research back in the day just because there were some docs like, oh, I want 70 to 110, and actually had worse outcomes because they got hypoglycemic way too often. So they have this euglycemia, or they allow the sugar to be all the way up to 140 to 180. That's really where sliding scale should start and where they have the best outcomes. Okay, because we know their sugar to be high because they're stressed in the hospital setting, right? So sliding scale insulin should definitely start it if you have steroids, you have TPN, tube feeding, octreotide. We said octreotide inhibits the whole GI tract, including glucagon, which would raise the sugar, but also including insulin, which is going to raise the sugar, right? If we inhibit insulin, which lowers the sugar, that's going to cause a rise in sugar. All right, someone has poor perfusion. So poor perfusion, right? You have glucose here, and we got a finger that is this big with this much edema, right? And you're trying to draw a sample from here all the way to our little glucometer, right? So then you have someone that's on a, 2 pressors, 1 pressor, right? 3 pressors, 4 pressors. That vessel's extremely tiny, and you're not going to have a reliable glucose, right? That blood that's been in there has been there for a lot longer compared to the rest of the body, right? So you want to get a more central check on your sugar when you have someone on pressors, especially, right? There's another note is giving like the long-acting insulins, right? Giving the sub-Q insulins. Hey, my sugar's still 320 and I'm on 30 units of Lantus and I'm giving 10 units, 3 times a day, and I'm giving 12 units, 15 units with each of my insulin checks. It's because you're giving them here, 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 and how much of that is actually getting absorbed into the circulation, right? So that's the idea, is you have to check it centrally in these cases, and you probably need to give it centrally, give the insulin centrally. So that's something to consider with someone in the ICU, is that they need to have are they appropriate for sub-Q insulin? Because if you have a patient on pressors, you've just removed all the vasculature from the sub-Q tissue itself. Okay, so you could have swings in your sugars, you could have abnormal absorption rates, you could have hypoglycemia episodes because you're getting this weird absorption as you get better perfusion and all the insulin gets absorbed. So we want to make sure it's as safe as possible when we're giving this insulin. Okay, so the total daily dose of insulin that these patients are getting, right? Again, we're starting basal insulin because their sugar is probably going to be high if they're stressed out. It's about 0.2-ish per kilo. So if they're 100 kilos, it's about 20 units, right? And usually it's 10 units is the basal insulin, and then the other 10, because split in half, will be given like before meals. But what if they're NPO? Then we might adjust that. So you're going to see most patients start about 10 to 20 units, right? If they're super, super thin, we might even start like at 0.1, much, much lower. If they're obese, they could go all the way to like 0.5 per kilo, but that's usually like 0.5 per kilo. Usually, they're NPO, they're not going to be eating, so they're at risk for hypoglycemia if we just hit them up with like 50 of insulin, right? Or because if they're like 0.5 per kilo and they're 100 kilos, or let's say 200 kilos, that's 100 units of Lantus. That's a crazy amount, right? So we have to, gauge what their body status is, if they're eating or not, and that could tell us if we need to, increase insulin or not. But the whole goal here is to get the sugar euglycemic. About 140 to 180 is always our goal for sugars. Okay, so we'll adjust their home insulin or they'll adjust their home meds, right? So we got to keep that in mind. We're looking at patients that are diabetic on the outside that already have therapies, right? And of course, they might say, oh, they're not. Why are they taking insulins? Because they are stressed. They're in the ICU. All right. So what are your causes of hypoglycemia? So we got someone that's low sugar because they got maybe too much insulin. Maybe you have someone that got Lantus or glargine insulin and they were now all of a sudden NPO. Or they had got glargine insulin just before their breakfast and then just after the breakfast they got a stroke and now they're NPO for 24 hours, right? So you can't take it back when you give that sub-Q insulin. You can't, it's like a snake venom. You can't take it out, okay? So in the hospital setting, one of the most common reasons for someone's sugar to be high, or sorry, sugar to be low, is because we gave a high amount of insulin and we can't take it back, right? So for instance, they come in and they say, let's DC steroids today. It's been day 5, usually it's 5 days of steroids, and we're gonna take off steroids today, right? So then they came at 6 a.m. before your 6 a.m. dose, no steroids for the day, but then last night you gave glargine insulin 28 units. Well, shoot, now that's gonna last for how long? At least 24 hours, right? So it takes 2 hours to kick in, and it's going to last for about 24 hours. So that during that day, you can be at high risk for hypoglycemia. Okay, so steroids changed, reduced, or removed, right? And insulin is the same. Well, that's a problem, right? So they DC the steroids at 6 a.m. and then it's 10 a.m. Lantus is due, right? And it's due 24 units. Are you going to give it, or are you going to pump the brakes and say, wait, maybe they don't have that steroids, they don't have the steroids anymore, right? So not eating, like a new stroke, like I mentioned, right? They had a last-minute procedure, went to the OR, right? They had a change in condition where they got intubated, and they still have insulin on board. So that's something to consider to when someone comes to the ICU, especially on RRT or something. You fix the blood pressure, you fix their pneumothorax, you got them intubated, you put a central line in, and now your sugar is 40. It's like it's because they probably got insulin the night before or in the beforehand. Okay, so how do you stop that? We give dextrose. Okay, so you give D5 water, as long as it's added to D5, just straight D5 water, D5NS, D5LR, you usually have D5. Your next question is, oh, are they NPO, right? Otherwise, they shouldn't be on D5 water. They should be getting like tube feeding, right? So they're NPO without D5 water, then you're going to be at risk for hypoglycemia. So D5 water is usually what's going to be fixing someone that is NPO. Something changed, right? They got tubed because they got a new stroke, or they got tubed because they had a cardiac arrest, and they got their long-acting insulin. Then we need to fix that with some dextrose until the Lantus wears off, till the glargine wears off. Okay, so they're still on long-acting insulin and they're NPO at midnight for a procedure in the morning, and the procedure gets delayed, right, because there's traffic on the 14, and then this happens, that happens, and then there's something else emergent comes in, and they finally get their test at 5 o'clock. It's like, okay, you're ready for your test, and why aren't you waking up, right? Because they have symptoms of hypoglycemia, okay, because we didn't add D5 water to their situation. And then what can happen in the hospital setting is glycogen loss, especially prolonged hospitalization. Right, you're stressed out, you're breaking down all your glycogen stores for 3 days, 5 days, 7 days, 10 days, and then now you're out of glycogen, right? So especially patients with liver failure or patients with severe infection where they've used up all their glycogen, now they have no quick acting source to raise their sugar when they are stressed in the situation. Okay, and then at home, this is more of like a reason why they came to the hospital kind of thing. But on the outpatient side, we look at is there new meds? You took a new sulfonylurea, or you took a new medication and you didn't, all right, they weren't checking their sugar, for instance, right? If someone does overdose on sulfonylureas, the treatment is octreotide, right? Octreotide just shuts down the GI tract, it shuts down the beta cells that sulfonylurea works on, right? Someone's not eating at home, that can make them hypoglycemic, right? If you're super, super sick though, maybe your hormones will start kicking in, you'll get hyperglycemic. But eventually that can waste away. You can use all your stores and you can then become hypoglycemic at home. All right, exercise, we're not going to focus on too much, but that uses sugars. And alcohol, ETOH, that is going to, you're not eating a lot of food if you're alcoholic, so they don't have a lot of good food intake. So what are your symptoms of hypoglycemia? We touched base on this, right? When your sugar starts getting low, glucagon gets released. Does that have any symptoms? No. Or you don't get, oh, my glucagon's up. That's not something that really happens, right? But you do get symptoms when adrenaline starts firing off, right? That's our SNS response, right? So they get sweaty, they get diaphoretic, they get anxious, they get tachycardic, tachypnic. Those are all SNS symptoms that happen when someone is hypoglycemic. Okay, so increased heart rate, respiratory rate, they might get palpitations, shaking, anxious, right? They will feel hangry too because it's probably the glucagon and growth hormone that be getting stimulated. But the other symptoms that might happen is after this is they're going to start getting neuroglycopenia, where they have a low sugar penia, right? Glyco in the neurons. So we have nerves that aren't getting the glucose they need, and those nerves are going to start to not function, and they don't function focally. So what is focal versus global? So global neurodeficit is just what? Someone's just altered, right? They are altered. They are not waking up, right? Versus something that's focal is they can't speak. They can't see out of one eye. They can't move their right arm. They can't move their left leg, right? That's a focal neurodeficit, right? That's why with strokes, we always do a sugar first to make sure it wasn't something easy like a low sugar that caused these stroke-like symptoms. And then you'll start getting global deficits with a seizure, coma, etc. Okay, so that's the idea behind hypoglycemia, what causes it and what the symptoms might be, right? So there's different precipitates out there, there's different drugs, right, like our sulfonylureas, right, critical illness, there's a malignancy of some site that's really rare. If you have an insulin secreting tumor, of course, that might cause a low sugar, right? And there's other problems that might cause a low sugar over time. Okay, so there's the idea behind hypoglycemia, and then the treatment is next. Okay. So you think of this algorithmically, whether they're alert or not, and whether they can take PO or not, right? If they can't take PO, they need to get IV form. If they don't have an IV, you need to give it IM, right? You need to give it IM to get their sugar under control, right? Or not under control, but in control, within range. So if they're able to take PO in green here, right? You have fast-acting carbs, not slow-acting carbs, which is an easy thing to say, but basically you want to make sure things that are not full of fat, make sure things are not like milky, which has fat, and then you want fast-acting sweets that are not sugar-free, that are going to raise the sugar quickly, right? Usually the ICU or the floors are going to have someone that is probably MPO or doesn't have an IV. If they're MPO, then you give IV glucose. That's easy, right? You give IV glucose, and usually it's if they're awake, it's half an amp. If they're not awake, it's a full amp of dextrose, right? And if they don't have an IV, well, you're going to insert one. But in the meantime, you're going to go grab what? Glucagon, right? And does glucagon make the glucose go gone? No, unfortunately, no. It makes the glucose go up when the glucose is gone. So it's going to you're going to give that IM, right? And it's going to make them vomit, 100%, right? So it's really something where you want to turn them on their side after you give it. So otherwise they're going to be a high risk of aspiration afterwards, right? So the whole goal here is to give some kind of sugar, and if the sugar is still low, you're going to repeat it, right? So we keep going back and forth, right? Keep going and then checking. You go back and then check. So it's this 15-minute rule, 15 by 15. Give 15 grams of carbs, wait 15 minutes, check sugar. If it's still low, then you're going to repeat back to the top. If it's okay, and it's okay times 2, that's our protocol right here at PRMC, right, is to make sure that we have a sugar greater than 70 times 2, then you are pretty much stable, right? You are okay. Are you going to check it again in an hour? Probably, especially if you know they're high risk, right? So we want to look at, those underlying causes. Is like, hey, let's add some dextrose because they're MPO, or let's start some tube feeding because they're on the vent now, or did they overdose on sulfonylureas? Let's start octreotide to reverse that sulfonylurea toxicity, for instance. Okay, so if your sugar's under 70, we keep doing it again and again until our sugar is more than 70. If they're at home, of course, they'll be calling 911. We look at underlying causes, see if there's something we can fix in the meantime. Okay, and again, the first step is to assess if they are conscious or not, right? If they can take PO or not. If they can't, then they probably get IM glucagon if they don't have an IV. If they have an IV, go ahead and give stuff IV, right? And it depends on your protocol here and there, but here at our hospital, we give half an amp if they're awake or comatose. Which one? Half an amp is given if they are awake, and a full amp if they are comatose, not waking up.
More, these pretzels are making me thirsty.
Kramer, what happened here?
I don't know. What should we do? We called an ambulance. Does anyone know first aid?
Shouldn't you do something with the extremities?
What extremity?
What's an extremity?
Well, you raise the feet, get blood to the head.
You raise the head, you get blood to the feet.
Okay, what about a cold compress? They always do that.
I don't have a washcloth.
Well, use a paper
You
towel.
can't put a paper towel on his head.
What about a big sponge?
How are you gonna hold it on there?
Use a belt.
No.
Should we walk him around?
Yeah.
I've seen him do that.
No, that's for a drug overdose.
Maybe that's what he's got.
No, Kramer, I just had lunch with him. He didn't leave the table.
Well, he could have dropped acid when you weren't looking.
He is not a drug addict.
Hey, you know what? Maybe he's a diabetic. He might just need a cookie or something.
A cookie?
Can you give him a cookie?
How's he gonna chew it?
We'll move his teeth. It happened to my uncle. The sugar revived him.
Careful, you're getting crumbs all over him.
I got him chewing, but I don't think he's gonna swallow.
All right, you know what? Let's put a few cookies in a blender and he could drink it.
Cookies don't liquefy.
They do. You can liquefy a cookie.
Well, then I'll get a blender. What blender? I don't have a blender.
You got a blender?
I would know if I had a blender.
Where's the ambulance?
So hyperglycemic patient can be a patient who has type 1 diabetes, type 2 diabetes, or it could just be hyperglycemia from being in the hospital setting, right? Doesn't necessarily mean they have diabetes. But if they have diabetes, they're a higher risk for more serious complications, right? But what causes a type 1 diabetic, or sorry, someone to get hyperglycemic, right? It could be a stress situation. It could be our fault, which is iatrogenic, right? So what causes that's not our fault would be like a stress. We got too much adrenaline, too much cortisol. Cortisol gets released naturally when you have a systemic inflammation, right? If you have an inflammatory process in your in your body, that's going to put you at risk for a stress hyperglycemia, which is 12% of hospitalized patients, right? So the hospital itself, just being in the ICU, can put you at risk for hyperglycemia or stress hyperglycemia. That's why our goal is to get them under what? Under 180, right? That's our goal for the ICU. And someone could have that just from their own endogenous steroids, from their own stress response themselves, their own adrenaline, their own cortisol, or it could be because of steroids that we gave, right? That's usually going to be our fault, right? That we gave too much of the steroids, or they're on steroids and we didn't pay attention and we didn't add what? Add some sliding scale coverage, right? So we got to add sliding scale coverage to make sure that when they're on these things, that we are fixing it, right? At home, they might have what are called sick days, where they have when they usually type 1 diabetics are higher risk for this, where they're making sure they're not going to go into decay. So they check their ketones, they check their sugars, they make sure they take insulin because they're going to be hyperglycemic at home. Okay, so they have persistent fever, their sugar's still high, their ketones are still positive, like not just little amount, but a lot amount. They need to come in to get help. Okay, call 911. But iatrogenic, what's the reason why that a patient's sugar goes high? Not because of their own steroid production or they're on too many steroids. It's because we have dextrose and IV fluids that we didn't pay attention to, right? So IV piggyback, sometimes some medications are mixed in dextrose, right? So I think, is it phenylephrine, or I know epinephrine is mixed in dextrose, but there's other, some of our drips that we're giving can be mixed in dextrose. That could be causing the hyperglycemia. And we can always get it mixed into something else, unless it absolutely has to not be, it's absolutely contraindicated, okay? So tube feeding, calories, so we're not being aware that the tube feeding might be causing it, so we could get more dense caloric feeding if need be. So get involved dietary nutrition services to make sure that they are getting the right amount of tube feeding per calories, but also some of them might not be extremely glycemic. So like Lucerna is low glycemic. It's not going to raise your sugar as much as something like Gevity would. Okay. And then residuals. So just as a note that if the residuals are super high, like gastroparesis is very, very common with diabetics. They have like a distended abdomen, they got all this nausea and vomiting, and then you realize the residual is pretty high. That could be a sign that they have a risk for hypoglycemia because they're not getting the calories in the first place. Now, does this mean you should check residuals in all patients? No, we talked about this in pancreatitis, and enteral nutrition is more important than checking residuals. And when we check residuals, we actually reduce caloric intake. So it's only done when we see something that makes us suspicious for high residuals, right? And then TPN patients, they are high risk for hyperglycemia, and we can actually add IV insulin. What's the only IV insulin we can give? Regular insulin. So you can add regular insulin to the TPN. So that's pharmacy's fault. Pharmacy didn't look at the sugars the previous 24 hours. They should have, for the next 24-hour bag of TPN, they should have adjusted it and increased the insulin that was in there. Okay, and then if you take insulin, sorry, you take all this insulin you're getting per hour, and if you take the TPN down, like it runs dry, for instance, what do you have to do to prevent hypoglycemia? You have to give D10, right? So D10 water is a substitute, so they don't get rebound hypoglycemia. And there's something called Dawn phenomenon and Samoji effect, which is our fault, right? It's usually a prescriber error. So you'll see like with Samoji is so much insulin. They prescribe too much insulin at nighttime. That's usually when they're giving like MPH and those half insulins where it peaks at 8 hours, and you get this dramatic drop in blood sugar in the morning, and then your body secretes all kinds of norepi and cortisol and all kinds of stuff to raise the sugar, and by the time you check it at 6 a.m. it is extremely high. Okay, so it's usually they just got to reduce the insulin dose at nighttime, or use long-acting insulin instead of this ancient half insulins, right? These MPHs and 70/30s and such, right? Dawn phenomenon happens when they get hyperglycemic because of the circadian rhythm of hormones. Basically, we mentioned that cortisol, it has a circadian rhythm. It's highest at 6 a.m. So at 6 a.m., right, you're going to have a high sugar. It's a dawn phenomenon at 6 a.m. or 5 a.m., wherever you're at. I'm not sure if you can get dawn phenomenon if you live in Alaska. Either way, signs and symptoms of type 1 diabetes are of hyperglycemia are just gonna be like our diabetics, right? They're gonna have the 3 Ps. They're gonna get dehydrated if they're not drinking water. And then how do you fix this? Well, we have to, we're gonna do sub-Q insulin, long-acting insulin, and they may need IV insulin therapy to get that insulin corrected, okay? And then what are the complications of hyperglycemia with insulin coverage is hypoglycemia, ironically. So we have to be alert to make sure we're not overdoing it, right? And then if we don't get the sugar under control and it keeps getting higher and higher and higher, it could be because we don't have enough insulin. That's called insulin waning, like with sub-Q coverage. Or they can develop the serious complications of DKA or HHS. So HHS is only attached to type 2 diabetics. DKA can be type 1 or type 2. Okay, type 1 being more common for our hyperglycemic complications. So it bears repeating. We talked about this in IV titrations with the insulin advisor. The insulin advisor can be used for diabetic complications such as HHS, such as DKA, but it can be just used in critical care if our patient's sugar is sustained above 200, right? We tried all the tricks. We tried our long-acting insulins, we tried our sub-Q coverage, and it's not working. And it could be because our vasculature is more vasoconstricted. It's getting more and more vasoconstricted as we go along, right? That could be the reason why we're not absorbing this insulin that we're giving sub-Q, right? It's like, why is the sugar still high? It's because this never got absorbed in the first place, right? Or our sugar checks weren't entirely accurate. So that's why you would check it centrally and you would give IV insulin, right? So that's where you give the IV regular insulin to get their sugar under control, and that's where we're using the critical care insulin advisor. All right, so what's the whole point? Why even worry about it? WBCs don't work when the sugar's over 200, right? They literally get glycated just like our hemoglobin did. They get crystallized and they cannot fight infections. Our immunoglobulins or our antibodies get glycated as well, and they can't attach to the foreign pathogens as well, right? So we want to make sure that we are potentiating the immune system as much as possible by getting the sugar under control. Okay, so what else? So we'll talk about DK and HHS. Just FYI, cabbages, they want to get their sugars under control immediately post-op. They usually come out with an insulin drip out of surgery with them to make sure that their wounds heal appropriately, right? So what could be causing, when you start insulin advisor, when you search for advisor and it comes down, why would you need to, what are the next steps? Well, we have to make sure if the sugar's over to 500, we have to have a lab value. It's just a computer system. It can't just take greater than 500. It has to have 1 hour sugar and the next hour sugar. So if 1 hour sugar is greater than 500 and the next one is greater than 500, it's not going to know what to do. It wants to drop your sugar down nice and safely, usually about 50 to 100 points per hour. That's usually the goal for most of these insulin protocols. All right, and we'll talk about that briefly when we talk about DKA.